So is the slide visible?
Yes.
Yes, thank you. So thank you, doctors, and good evening, everyone. I'm Dr. Prachi from Shield Healthcare, and a warm welcome to all of you. And thank you for joining today's webinar. We have eminent speaker today, and very happy and honored to have Dr. Priya Kannan with us. Ma'am is Director and Clinical Embryologist, Garbha Raksham Bigai Fertility Center, past president of ACE India, and also authored many chapters in books, participated in clinical trials, provided many guest lectures, and also participated in speaker events. So with this, may I invite and request ma'am to deliver her topic or lecture on how to improve success rates in ART with male infertility. So thank you very much, and over to you, ma'am.
Thank you very much for the kind introduction and for giving me an opportunity to talk on this topic. It is a very simple topic in the sense that everybody might have heard about things, but it is just that to assimilate things and to put into perspective for that on an everyday basis, this is one of the most important things that we use on an everyday basis in an IVF center. So to start with, I'm just going to start sharing my slide. Okay, just a second. Okay, now I can share my slide. Yes, and full screen. Yes, so we would just talk on ART in male infertility and how to improve the success rate. As we all know, male factor contributes to infertility around half the time, that's about 50%. And 1/3 of the time, it is the main reason that we have to treat people to help them get pregnant. The most common causes include lifestyle factors, problems with sperm production, or motility or morphology, sperm antibodies, chromosome and DNA abnormalities, hormonal problems, and sexual dysfunctions as well. Fortunately, most causes can be readily diagnosed and most can be treated or at least can be overcome to help the couple conceive. Now, there are 3 procedures that we'll be looking at when a patient comes in for ART procedures. One is, am I going to offer an IUI for this couple, or am I going to offer an IVF or ICSI? It is not the point of am I offering or what. We should be thinking in a different way. We should be thinking, is this semen sample fit for IUI, or is this semen sample fit for IVF, or is this semen sample fit for only ICSI? That is a demarcation that we need to do. And that is very, very important to do right from the beginning so that we can start and make the diagnosis, so that we can start preparing the patient in that particular way. For example, somebody who is going to go for, we know that the patient is going to go for ICSI, there may not have, and the female partner is completely fine, there may not have a much necessity to do a lot of tests on the female. So we would be not, may not be, if you have a scan, 3D scan, that's how you can see the uterus. There may not be a need for hysteroscopy, there may not be a laparoscopy, there may not have a lot of things that may not be needed. So straight, we see ovulation for 1 cycle and then we prepare the patient and take them for ICSI. Whereas if you are going to do IUI, then definitely, yes, we do need some procedures to be done. So that is a small demarcation and differentiation that we must be able to do right at the start of the procedure so that we can prepare the couple in an accordingly. And another thing, important thing is if we can talk to the patient accordingly as per this and then counsel the patient, then they are also prepared on how they would be going ahead. So, so the first thing that we must do is identify the cause of man's infertility, which is as much of an art as is a science, because it's just not just a sample. It's a lot of things that we need to do around it. And diagnosis is the key. The moment we make it, the plan for that patient is set right away on the table for us. And the first step to an evaluation is A, a physical examination, B, a semen analysis. A physical examination is paramount when we are going to do like any other patient that we have. When we have a female patient, we do a pervaginal examination, abdominal examination, examination of the breast, and then we do a vaginal scan to see the other things. And so a physical examination is primarily done prior to we go ahead testing the patient. The same way, it is highly recommended and it must be made mandatory that we do a physical examination of the male partner as well. So this gives a huge amount of information as to the presence or absence of testis, or if it is absent, where is it present? Is it like a nibble testis such that there are no, the tissue is not there? Or is it like testis present elsewhere, which means we have to take action accordingly. Presence or absence of sexual, secondary sexual characteristics. When we are always looking at the testis, one important thing that we like to know, apart from the where the position of the testis, is the volume of the testis. Another thing we have to know is the presence or absence of vas, and there are various other abnormalities such as varicocele and other things. The next important thing that, and sorry, I forgot. So who should be doing the physical examination? If we have a urologist who is trained, who can do it, excellent. That's the best thing that we want. If not, I think any gynecologist should be able to do, but if you're not able to do, you don't have time to do it, then you can have any MBBS doctor who will be happy to do a scrotal examination. I think we are all taught in MBBS of how to do a scrotal examination and abdominal examination the same way. I think that's a simple thing. Just have a male, if there's an uncomfortable feeling or something, just have a male MBBS doctor who would be happy to do it for us. A semen analysis is the single most important test that we'd be doing to assess the male partner, apart from the physical examination. Hence, the person who is doing the sample, assessing and reading the sample, must be quite well trained. We don't want anybody looking at the semen sample and giving us an answer. There is a way that which we train the person. They do at least about 100 samples before we even give them an independent charge of doing and giving me a result on that particular sample. And while they are doing it, there will be an assessment by another experienced senior andrology technician or a junior embryologist or a senior embryologist who will be assessing, like, you know, what is the about the inter person variability on the count, motility, when they are doing the morphology, everything will be quality control. There are some courses which, like, you know, not exactly courses, there are through the ACE, we had conducted a few WHO courses where we trained junior embryologists, senior embryologists, and lab technicians, a lot of lab technicians all over the country on how to assess a semen sample as per the WHO recommendations. Because as we all know, we all have to speak in the same language so that each of us can understand what other person is saying, and then we all to analyze each other's work is also very simple, and that way we can put forth our data for analysis as well. And hence WHO is the most important criteria on which we have to assess any semen sample. I don't think I need to insist on the importance of quality control and quality assurance when we are doing the semen analysis, because people might think it is just a semen analysis, but that is the basis on which we are going to plan the treatment protocol for that particular couple. And hence that way it becomes extremely important to do that extremely well. A uniform approach, as I had told you, in the interpretation of the seminal parameters is mandatory. The best example being the persistent variance in sperm morphology scoring between and even within laboratories. This ongoing error has been associated with inconsistent semen testing methodologies, meaning that many men at the margins of the treatment decision making can wrongly be either excluded or can be included sometimes as well, which is why a training is extremely important for semen analysis. Why I'm stressing so much on the training is because there is a huge variation in the semen analysis when we see it and when I get between the lab and other labs report. And I think that is the core. Not all DMLT people are good enough to give us a sample, good enough to give us a record, I mean a report of semen analysis for us to use in a fertility clinic, which is per se why we insist on patients giving us a sample in our center only for a assessment of the semen analysis in our center. Basically because they're all trained. Like I've trained like 6 people in our lab or can do that, and all of them have been trained intensively, including doing the WHO certification. A little bit about the semen analysis or based on the WHO 2010 criteria. The 2020 criteria is on its way. It will be published in maybe a year or so. Until then, we would be following the 2010 criteria. So just to give you an idea of how the parameters have evolved from 1980 to 2010, you can see that in terms of volume, sperm count, total sperm count, motility, progressive motility, vitality, morphology, and the leukocyte count. So I guess there has been a progression, and there is a difference, there is a change expected, and we have seen that draft as well. We have given a review as well. So there is a change, there's a slight change in the 2020 criteria, but then it is always a evolving parameter because it is based on the 5,000 men tested all over the world for that particular decade. But something I must inform you, or I must bring it to light to whenever you use it. As you would remember, in the 2010 criteria, the semen count cutoff was 15. The total sperm count was 39. Total progressive motility was 40. And the progressive motility was 32. Let me put things into perspective for you. What we see there as the cutoff is the lower 5th percentile that has been seen in the 4,500 men who were tested all around the world and who had fathered children. By no means is that the median or at the 95th percentile. So if you see, I remember when we were medical college students, we were taught that 60 million is the cutoff for a normal semen count, and still the median remains around 73 million. And I would have maybe another 1980s, it was on 200 million, the same remains the same. What we have at 15 is the bare minimum that we want to see for somebody to go ahead and have a spontaneous conception. Does not mean that people cannot have a conception at less than 15. There are rare occasions that they can have, but then what we have to keep in mind that with the 5th percentile or the 15 million with 40% motility and 32% progressive motility and 4% Kruger is the bare minimum that we wish to see as the cutoff for the semen analysis. For example, to give you an analogy, this 5% is a 35% pass mark in our 12th standard. For example, this is the 50% mark, and this is the 95% mark. So what we have here as the 5th percentile is the bare minimum to pass an exam. Just to give you another idea on how to grade. Why am I spending so much time on semen analysis? Because as I've told you, this is the most important test that we'll be doing to assess the fertility status of a male. Always we suggest that whenever somebody is grading or grading the motility in a semen analysis, they must grade it as progressive motility, non-progressive motility, and immotile. A progressive motility is when the sperm can swim forward in a straight line, like a guided missile. Non-progressive is when it doesn't move forward, but it's able to move its tail. Immotile is when it doesn't move at all. we wish to see there has been a increasing importance to the progressive motility of the sperms, and hence to grade the sperms based on the motility is very important. It is not just the progressive motility or the total motility that we want. When you want a functional parameter to be tested, to be created for the sperm, there are 4 sperm parameters that are probably most frequently examined and cited in many publications. One is the IMC, that is the inseminating motile count, sperm morphology using the strict criteria, the total motile sperm count in a native sperm, and total motile sperm count, total motility in the native sperm sample as well. So here, these are all the functional parameters, sperm parameters that we might have to calculate based on the SAR report that's given to us. Why are we bothered about the sperm motility? Because we know that the sperm motility is a predictor of pregnancy in patients undergoing IUI and has been a topic of discussion forever. And it is a never-ending discussion that there are lots of pros, people who are published saying that yes, it has got a huge predictor value. And there are others who said that it's got absolutely of no value as well. But ever since 2004, we have seen publication which said that patients with the original sperm motility, which is more than equal to at least 30%, had a cumulative pregnancy rate more than the patients who had less than 30% motility in the sample. Coming to morphology, this is another important aspect of a complete semen analysis. A complete semen analysis will have looking at the count, the motility, and the number of normal sperms that we see in the motility, which is the morphology. But when we have to look at morphology, still I do see reports which says like 60% normal sperms, 70% normal sperms, which is absolutely even superhuman effort, I would say. Then we are assessing the morphology of a sperm. There are 3 parts to a sperm: head, the midpiece or the neck, and the tail. And all 3 have to be taken into consideration when we are talking about a normal sperm. Any abnormality at any part of the sperm, may it be in the head, neck, or the mid tail, is called an abnormal sperm. And hence, what the WHO recommends is to do a sperm morphology using Kruger or Tiger-Bird's criteria. It is otherwise called the strict criteria. According to Kruger's criteria, the IVF outcome was suboptimal when normal sperm morphology was less than 14%, which was the cutoff like maybe 20 years ago. And it is the worst if it is less than 4%, which is the cutoff from 2010 onwards. The sperm morphology must only be considered as an indication of fertilization potential and not as an absolute indicator of sterility. That is just how one of the morphology slides that we do using Yosin and Nigrosin saying there are a lot of other diff-quick and other pre-prepared stains as well which can be used. But I just also want to bring to your notice about this. This also is a sperm. It looks quite normal to me as well. This also is a sperm. This looks, all these. But you see that this is taken up the stain and this is not taken up the stain. So there is a difference in this. When it takes up the stain, we would call it that the sperm is dead, and then especially the supravital stain, and it will be live when it's not taken up the stain. And hence, we would have to, whenever we are doing the morphology, we would also like to pick up, do side by side the supravital staining to see how many sperms are actually alive or dead. Why is it important? In certain situations where there is 100% immotile sperms, then we have to do this so that we know that if there are any motiles, any live sperms at all in that sample that has been given to us. One of the most important functional parameter that we have to calculate based on the SAR report is the total motile sperm. That is total motile sperm count in that particular ejaculate. It is a combination of sperm count, motility, volume of that ejaculate. It is calculated by multiplying the ejaculate volume by the sperm concentration into percentage of the motility that we have seen. For example, there is volume into density into motility in percentage. For example, if we see this, if the semen has got a volume of 2 ml and the sperm count, the density, not the total sperm count, the density is about 20 million and the motility is 30%, that is 30 divided by 100, the total motile sperm count would be 12 million. Whereas if it is a 2 million with 10 million, only 10 million count density, but then if it has got a motility of 60%, still our total motile sperm count would be 12. Look at this. Even if you have 60 million and only 5%, but only 5% motility, the total motile count drops straight to 6. And here, when you have as high as 40 million, but only 5% motility, then the total motile sperm count would be 4. Why is this important? We are coming to this soon. But just do remember that here, that's a stark difference. A 20 million count, we will say, okay, fine. But then a 10 million count, we would usually say, okay, that's not a very good sample. But look what it's turned out to be. The total motile sperm count, of this ejaculate, is as good as the one we saw in 20 million and even better than the one we saw in 60 million and 40 million. So it is very important to calculate this particular functional sperm parameter. And it is, I would suggest that you can have your own cutoff. There is a cutoff which is available from all publications, but then you could also derive at your own cutoff for your own based on the pregnancy rate that you achieve in your clinic. Here, there has been lots of publication about total motile sperm count ever since 2004 and 2000 and everywhere. I'm just showing you certain very important publications here. Here, Bradley et al. In 2000 showed that an average total motile sperm count of 10 million in the ejaculate, in the native count, may be a useful threshold for decision taking about whether to treat the couple with IUI or IVF. Excuse me. So whenever there is an SAR, always you can either you do it or then you can ask the lab to do the total motile sperm count as well and give it to you. That will be a good way of deciding. Here again in 2001 there was another publication which said that when the average total motile sperm count was under 10 million, IVF with ICSI was a more cost-effective treatment protocol than IUI in their clinic. In case of insemination with cryopreserved sperms samples, total number of motile sperm, which was less than 20 million, significantly decreased the pregnancy rate, probably because of the poor functional competence of frozen thawed spermatozoa. In a recent analysis, a retrospective analysis by Mankes et al. In 2019, which also concluded that the pre-wash TMC was a poor predictor of live birth. There were no live birth, but they also have said that there were no live birth when the pre-wash total motile count was less than 2 million sperms. And live births for women more than 30 years, 37 years with IUI was significantly lower than in women with less than 37 years. That is about the pre-wash, that is before you can process the semen sample. After processing the semen sample as well, it is mandatory that you have a look or have this calculation also as part of the post-wash. They'll give you the count and motility, but they ask your embryologist to give you the post-wash total motile sperm count as well. Because the specificity of the post-wash total motile count defined as the ability to predict failure to become pregnant was as high as 100%. The sensitivity of the test defined as the ability to predict pregnancy was limited. However, its ability to predict failure was as high as 100%. A systematic review which was conducted by Omblet et al. In 2014, which was a landmark publication for IUI, proposed that IUI can still be tried with an total motile sperm count post-wash of more than 1 million before directing the patient to have IVF. However, they also said that the pregnancy rate in such circumstances was very low. In a retrospective, another retrospective study comprising of 1,166 couples undergoing IUI cycles, Lemons et al. In 2016 found that the pregnancy probability significantly decreased when the post-wash TNMC was less than 1 million. In 2017, Madbully et al. In 2017 concluded that a post-wash TNMC of at least 5 million or more was significantly associated with a higher pregnancy rate. They also went on to recommend including a pre-treatment semen processing during routine male fertility workup for proper patient counseling and direction to suitable assisted reproductive technique. That is something I have included in some of the patients when I have a doubt about how to proceed with the treatment protocol. So whenever we have a semen sample, we also request the patient to go for a trial wash of the semen sample, of the ejaculate. So that when at the end I would get a report of what was the count and the motility and total motile count in that post-wash semen sample, which gives me an idea. If it is anything less than 5 million, I would suggest them to go for ICSI. At least between 1 and 5 million must be there for me to let them for me to suggest to them to go for IUI. Otherwise, less than 1 million, definitely they are going only for ICSI. And inseminating motile count of more than 1 million with IUI is probably the best cost-effective treatment before starting IVF. And hence, the cutoff for a IUI must be post-wash of having at least 1 million motile count to be given. My cutoff, if you ask my cutoff for IUI and IVF, a pre-washed total motile count of at least 5 to 10 million must be there for me to even go for a trial wash. A post-wash 1 to 5 million is my cutoff to give them, to suggest to them that IUI or IVF, because otherwise their failure rate is going to be quite high. And anything less than that, anything less differing from that, I would straight away suggest an ICSI for that couple. Insemination cycles, there was a very recent paper, as I was just telling you before, with the 1,117 women with 2,912 IUI cycles. The viable birth was achieved in 275. That is about 10% of the cycles, of which they had segregated also when the treatment was futile. They said that with less than 1% viable birth rate, they call it futile care, was identified when women more than 40 was inseminated, regardless of the stimulation type or inseminate motility. There was another paper in which it said that they had no live birth when they did performed IUI in women more than 40 years, and many had published very poor pregnancy rates when women more than 37 were offered IUI. So those are the most important parameters that we check for in a semen sample to decide whether is that sample IUI-able or IVF-able or ICSI-able. Every sample that goes through us, we must be bringing the thought to our mind to ask, is this sample, can I do an IUI with that or no? Should it go only to IVF or no? Should it be only for ICSI? That is a decision that we can take immediately the moment the semen analysis report is on our hands. How else can I improve the pregnancy rates in the couple? For example, in IUI, the time interval. The IUI pregnancy outcome is enhanced by shorter intervals from semen collection to sperm wash, from semen wash to IUI time, and from semen collection to IUI time. The shorter is the interval between semen collection to the IUI, the better the success rate will be. This is what was published in 2004. Similarly, the same was published in recent times as well in 2018, which said that among 556 couples who had 84 cases of successful clinical pregnancy, and the pregnancy rate was calculated to be around 15%. The shorter intervals between semen wash to IUI, semen collection to IUI were significantly shorter in pregnant women than in the non-pregnant category. The semen wash, which was performed less than 40 minutes after semen collection, resulted in higher clinical pregnancy rates than did semen wash performed more than 40 minutes after semen collection, to the difference of 19% versus 6%. When the IUI was performed less than 60 minutes after the end of the semen wash, had a higher pregnancy rates, about 17%, compared when IUI was performed more than an hour after the sperm wash, which fell to only 4%. Likewise, when IUI was performed less than 90 minutes from semen collection, resulted in higher pregnancy rate than when IUI was performed more than 90 minutes after semen collection. So it is as compared to 18, as high as 19 versus 12 minutes. This is exactly the timeline that I've given to my andrology lab. When the semen is collected, they would leave it for liquefaction for about 20 to 25 minutes, maximum about half an hour. After that, they have to start, even if it doesn't liquefy, they have to start breaking the strands and start preparing the samples, which will take about 45 minutes. So that's about an hour and 15 minutes in total. And then by 1.5 hours from the semen collection, the IUI must be done. That's the timeline that I've given in the IUI in the andrology lab in our clinic, which is followed per se. How else can we improve the factors? I have to improve the sperm motility. How do I improve sperm motility? As we know, the sperm motility does have a relation to pregnancy rates as well. The lifestyle modifications such as consuming nutritious diet, regular exercise, withdrawal from substance abuse, smoking and alcohol consumption can improve semen parameters considerably, especially sperm motility, which is dependent on 80% of the times on lifestyle modifications. That is a huge list of what can affect what, is it reversible, and what is the treatment, from tobacco, alcohol, to various substance abuse, to BMI. BMI, yes, that is one of the major things that we are seeing now. Yes, and the therapy as well. And as opposed to as well the healthy habits such as no tobacco. What is the relevance to ART? It's quite high. Low alcohol is also high. No recreational drugs is also high. Antioxidant rich diet is also has got high. Moderate exercise also has got a good effect on the good positive effects on the semen sample. How else can we improve? We can definitely improve, or there are publications which are both pro and cons about the oral supplementation of synthetic drugs or vitamins, trace elements, and other natural compounds which has been historically used for enhancing the sperm motility in men. There are most widely used approaches and based on the mitigating the oxidative stress in the testicular environment using antioxidants. What are the most common molecules that we use? We have used antioxidants such as vitamin E, coenzyme Q10, L-carnitine, vitamin C, lycopene, alone or in combination with trace elements such as selenium or zinc, have demonstrated improvements in sperm motility after oral administration. However, yes, there are also contradictory reports to this as well. So, but however, I think in practical purposes, for all practical purposes, we do have all our patients on some amount of antioxidants, definitely on treatment, at least until the fetal heart rate is established. The next one, which everybody keeps talking about, and there's a debate around it every conference, DFI, sperm DNA fragmentation index in the sperm. Bungham et al. Reported that the possibility of pregnancy using IUI was close to 0 when the DFI was as high as 30% in the sperm using SCSA, and that elevated DFI were a predictor of decreased pregnancy rates and delivery rates after IUI. Another publication reported that pregnancy was difficult when the sperm DNA damage was even at least about 12% or higher using a different method, that is the tunnel method. On the contrary, there has been reports which suggested that there was no correlation between sperm DNA damage and clinical pregnancy rates after IUI, and the samples were analyzed using this is a different method, sperm chromatin dispersion method. Measuring sperm DNA damage is beneficial in predicting IUI results ahead of time, and when sperm DNA damage is extensive, other methods such as IVF or IVF-ICSI should be considered. How do we treat sperm DNA fragmentation? Most important is lifestyle modification. Other things, whichever can reduce the DNA damage, such as infection control, addition of antioxidants, especially vitamin C and vitamin E in their full dose, that is 1500 milligrams of vitamin C and 400 milligrams of vitamin E, varicocele repair, advice of micromanipulation based fertilization methods, and testicular sperm. One important advice that we do use when we are using such high DFI samples for ICSI is we want the freshest sample. That is, we request the male partner to have an ejaculation the day before ICSI, even on the morning of ICSI, and after an hour or so, we ask them to collect a sample. So even if they are not able to collect twice in the same day, but we request that the male partner has a maximum of at least only a day as abstinence. Another parameter that has been talked about for quite some time is the resting after IUI. Yes, it has been proven way back in 2009, and it still continues to be that 10 to 15 minutes of immobilization after IUI can increase the pregnancy rates. This, I think, is one forest chart that none of us can afford to forget. This is what was published following the Esri-Capri workshop in 2009, which told us about how there is a positive effect on the controlled ovarian hyperstimulation using gonadotropins and IUI. There was definitely a favoring of the pregnancy rates when gonadotropins were used for ovarian stimulation for IUI cycles, and it still remains the same. So we have spoken a lot about how to improve tips of how to improve the pregnancy rates in IUI. Well, coming to IVF, when do I select a sample for IVF? I'll say, okay, this is not for they have not conceived after 3 cycles, or when they have just walked through. I see that their count is not as good for semen normal life or for even IUI. So what cutoff do we have to take that sample for IVF? It must be at least about 10 million, which is the base. 10 million with at least 30% motility and 15% progressive motility must be there before we advise for any IVF procedures, despite the fact that pregnancies can be achieved with lower parameters, but then this can be achieved in lower parameters, but the chance of achieving is the probability of achieving is much lesser. When the spermatozoa has a VCL, if at all you're doing CASA, this is something that you can look for. If the spermatozoa has a VCL greater than 65 micrometers per second and the straight line velocity is greater than 40 micrometers per second, IVF should be considered. The velocities of lower than these values to improve fertilization rate, ICSI is the only recommended method to use for such samples. Well, coming to ICSI, in ICSI, anything goes. If there is a sperm, we'd be happy to use it. And that's how it goes. Even as less a sperm, like as we say, 1 here and 1 there, or there are 100 million sperms. And this is how a testicular sperm sample would look like. You would see some samples here and some samples there, 1 sperm here, one sperm there. But then we'll have to pick up the sperm, wash the sperm. Here also you can see a sperm, but with an abnormal tail. Picking up a sperm, taking it to the PVP, clean it properly, free from all the other cells, and then check for morphology and use the morphologically normal sperm for ICSI. But yes, if you would ask me, motility, rather than the count, motility is also important for ICSI as well. Motility is an important parameter in ICSI as it helps the embryologist in picking a viable spermatozoa for micro-injection. Only if the sperm is moving, that's the only way that we do know that the sperm is alive or dead. Otherwise, we have to use other things such that we will touch them and see it tactile to see if they are moving, or else we can Haas test, or we can use the pentoxifillin or something like that to make them move. Especially in case of asthenozoospermia or if the spermatozoa are retrieved from testicular sperm aspiration. Low sperm motility and the concentration do compromise fertilization and blastocyst rate, even if the fertilization methodology used is ICSI. It impairs the developmental competence of early embryos, but it has got no impact on the implantation potential of the obtained blastocyst or the rate of top quality blastocyst formation. It has got no effect on the pregnancy rate or euploidy of the obtained blastocyst. Probably because as the sperm, as we all know, the midpiece or the neck of the sperm is very important for the cleavage, because it gives the cleavage spindle. Mainly because of that there is a lower fertilization and lower cleavage and blastocyst rates when the motility of the sperm is quite low. However, once the blastocysts are formed, the top quality blastocysts are formed, the implantation and the pregnancy rates are not affected by this. This is one paper that I would suggest that you can go through. It has been published by our own group from Manipal, by Dr. Guru Prasad Kaltur and Satish Adiga and his group. This gives you quite a good information on all the current insights and the latest updates in sperm motility and its associated applications in sperm reproduction. And another paper that I will also suggest for people to go ahead and read is another paper that has been published by our own group in SRMC by Dr. Sanjeeva Reddy's group on the DNA sperm fragmentation and its importance in assisted reproductive techniques. So what are the major take-home points from this talk? One is, please always have a physical examination for the male partner. Make sure that the semen analysis report is done by somebody who is well trained to do it. Always do a morphology of the sperm to know how many normal sperms you do have, because less than 4% normal sperms, it becomes an ICSI sample. IUI or IVF we are prone to have poor fertilization and poor pregnancy rates. We must make a diagnosis of every sample that we look at. Is the sample IUI-able or IVF-able or ICSI-able? So we must be able to segregate each sample such that it is easy to give a treatment protocol for the patient. And as the moment we make the diagnosis, we must use the appropriate method of ART so that the patient, it becomes cost effective, and the time to pregnancy is also very less. And before any of these methods that we use for treatment, we must insist on lifestyle modifications and oral antioxidants for at least some period of time prior to we take them for ICSI or IUI or IVF. We can give them at least 2 to 3 months time before preload them with the antioxidants, reduce the oxidative stress in the testes, and then we go ahead and use that semen sample. Thank you so much for the patient listening, and I'll be very happy to take any questions that you wish to ask. Thank you so much for this good opportunity.
Thank you, ma'am. Thank you very much for that wonderful presentation. Thank you very much. You have covered beautifully all the points. Ma'am, we'll wait for questions, but before that, one question from my end. Um, Fragmentation, DNA sperm fragmentation generally is not indicated for all the male patients. So, who are those patients in whom you would recommend DFI testing?
Okay. So for DFI, we don't do it, as you rightly said, it is not done for everyone. It is done for very, very few people. People who have had, I generally do when we see some other parameters such as a varicocele or something like that, or there is a huge amount of infection. But I generally have restricted myself now to do sperm DFI only in patients who've had implantation failures or poor quality embryos or recurrent pregnancy loss, or old, like, more than 40 years. These are all the few people I have restricted myself to do DFI. We don't do it for everyone nowadays.
Right, ma'am. Thank you very much. Ma'am, would you also recommend antioxidant therapy to all the male patients, irrespective of the cause, who are coming to ART? Is it viable? Is it right to do?
I think we don't have much of evidence on that. But then let me tell you practically and frankly on what the clinical practice is. Yes, we do give for everyone. Even though we may not give a huge, like, a combo which costs a lot, the basic minimum that I would definitely give is at least a vitamin C and vitamin E.
Right, ma'am. And that is what.
These are these three are my most favorite.
Right, ma'am. And would you recommend for a couple of months, 3 months? So how long would you recommend?
2 to 3 months.
2 to 3 months.
But I don't stop. I mean, we don't prevent them from getting pregnant at that point of time, but we do encourage them to have regular intercourse and try for spontaneous conception. But then if I'm going in for taking them for a procedure, definitely for 2 months, I prefer to give them antioxidants.
Right, ma'am. And what lifestyle modifications, guidance would you like to give male patients?
For all, I advise them on diet, daily walking, reduce the BMI whenever it's necessary. Diet, I always tell them to have at least 2 vegetables and 2 fruits a day, 3 liters of water a day. Cut down on all the junk. Whatever possibly can, I ask them to do. But then I think the complaints has been much better during the COVID times than the non-COVID times, I must say.
Right. Or maybe alcohol and cigarette smoking.
No, that's an absolute no. That's no alcohol, no smoking. Everybody must stop. The moment we think about a procedure, everybody must stop it.
Right, ma'am. Thank you very much.
Thank you.
Ma'am, I don't see any additional questions in the chat box. So thank you very much for giving us time and for that wonderful presentation and covering all the topics. So it was really a beautiful presentation. Thank you very much, ma'am. Thank you to give us time. Yes.
Thank you so much. Thank you very much for the invite.